Welcome to the final part of this educational video. I'm going to specifically show how to get to the L5 dorsal rami. The key things that makes the L5 dorsal rami a bit more difficult is the posterior superior iliac spine and the pedicle of the S1, which makes the angle of approach a little bit more difficult than the other levels. So this is a squared view of an L5-S1 disc, and as you can see, our target is in this sacral ala, which is the superior articular process of S1, and the sacrum, where we're trying to aim to get into this groove. So we can start approximately S1, S2 for Raymond, and I think as you can see, the posterior superior iliac spine on the way. So if you start too lateral, this is going to be in your way. If you start too medial, this is the pedicle, which is around here. So if you start too medial, this is going to push you out and avoid you getting into the target. So you want an ideal target where this is the target and you want to be straight in this line without this posterior superior iliac spine coming into your way. I've chosen this place because I can actually navigate the needle more medial to start with using the curvature, and then turn it left and then turn it right again. So this is more or less like an S-shaped movement towards the target. So as you can see, the needle is just past the posterior superior iliac spine. I'm just getting it. If I carry on in the same trajectory, I'm probably going to hit the pedicle, which I have hit the bone now. So with the curvature, I have rotated the needle to go outside. And once I've gone outside, I've then rotated the needle back again to get it into the position. So this is a very important way of, this also shows you how important a curved tip is, so you can actually navigate these places without having difficulty. So this is the initial view where I'm looking at the inferior view. As you can see, that's the curvature as you are looking at the L5-S1. This is more like a V shape, and you can see my needle is very much in the middle of this V shape. I then look at this further down, so you can see I'm actually touching the bone all the way through. So this is the further inferior view to make sure that you're touching the needle. Now I've gone to a superior oblique view, and I can see there is a little brim of bone still left, and I'm just going to advance it. So sometimes it's also easier. So if you chose where the sacral ala is, which you kind of target, you found your target, you can actually rotate it further inferior to try and see your trajectory. In this particular case, you can see it's the right side. There's the curvature. That's the landing strip that you want to go. That's your starting point on the X-ray, and you can see you're advancing the needle in the posterolateral view, which is 4 o'clock or 8 o'clock, depending on the side you're going to do. You then look at an inferior tunnel view to make sure that you're on the curvature, and you can see the needle is perfectly in position. And now you're looking at the superior oblique view, where you're able to advance the needle to make sure there's a brim of bone left. This is just a lateral view. So obviously, if you get a perfect lateral, then it makes it easier for you. But if you don't have a perfect lateral and a lateral like this, this can be quite confusing. And especially if the patient is slightly on the bigger side, you'd find the lateral view is of very minimal use. And I think, ideally speaking, you want to try and adjust your view and move your needle on a superior oblique, which is much more safer. So I tend to create the lesion in two ways. So once I'm happy, the needle is placed in the groove, I try and face the curvature towards the medial aspect, do a burn, and then rotate the needle to face the lateral aspect. So you get a nice, big lesion in the groove. So some salient pictures, I don't do any sensory stimulation, and I've not done it for more than 15 years, and I think we don't teach to do a sensory stimulation. In this particular scenario, because you're going to scrape through the periosteum, if you don't put local anesthetic, this will be a very painful procedure for the patient with an 18-gauge needle. So obviously, you will not be able to do a sensory stimulation. You'd still get a motor stimulation, but it is again optional, because once you get this radiological view, the chances of you getting to a dorsal root ganglion is extremely, extremely, extremely unlikely. Use plenty of local anesthetic, and I do use a little bit of sedation in very anxious patients, or even Entonox as a supplementary for these patients. 18-gauge, 1 centimeter active tip with a curved tip makes a massive difference in getting your lesion, and always two lesions, as I mentioned. Remember to warn the patient that they will have a new pain for a longer period and offer them good analgesia in the post-operative period. I just generally advise them to use paracetamol and diclofenac as needed. Thank you.